It's now 15 minutes after the hour, and I want to make sure that we can reconvene the meeting to begin the next session on tick-borne encephalitis vaccines. Dr. Kathy Paling, chair of the TBE vaccine work group, will provide an introduction and overview of today's session. And for the TBE session today, we will plan to open the presentations by Dr. Susan Hill for full discussion at the end of the three talks, but we will allow for clarifying questions as needed along the way. So first, I'll turn it over to Dr. Kathy Paling.
Okay, thank you, Dr. Lee. It is my pleasure to introduce the tick-borne encephalitis vaccine work group. Next slide, please. In the background, the Food and Drug Administration approved TBE vaccine manufactured by Pfizer and known as TICO in August of 2021. No tick-borne encephalitis vaccine has been previously licensed in the United States. There are no existing ACIP tick-borne encephalitis vaccine recommendations. And so the tick-borne vaccine work group was formed in September 2020 to review the use of the tick-borne encephalitis vaccine in U.S. persons traveling abroad and laboratory workers. Next slide, please. I need to thank all the Dr. Wilbur-Shen, my ACIP colleague, the ex officio ACIP liaison, technical advisors, and CDC participants, as well as ACIP Secretariat for many robust discussions. And a special thanks to our outstanding lead, Dr. Susan Hill. Next slide, please. The terms of reference for the tick-borne encephalitis vaccine work group are as followed: to review information on TBE, including its epidemiology, clinical presentation, diagnosis, treatment, and outcome; to review data on infection risk and burden for travelers and laboratory workers; to review data on vaccine safety, immunogenicity, and effectiveness; to provide evidence-based recommendation options for ACIP; to identify areas in need of further research for informing future vaccine recommendations, and then to publish an ACIP recommendation in the MMWR. Next slide, please. As a reminder, in October 2020, we introduced the work group, provided a background on TBE disease and vaccines, and summarized information on Pfizer's TBE vaccine. In February 2021, the TBE epidemiology in tick-borne encephalitis endemic areas was presented, as well as TBE among U.S. civilian travelers and laboratory workers, and TBE among U.S. military personnel. In September 21, we presented immunogenicity and safety of Pfizer's TBE vaccine. Next slide, please. Today's session, we're going to follow up on ACIP member questions regarding immunogenicity of 1 or 2 doses of tick-borne encephalitis vaccine, and then the evidence to recommendation for TBE vaccine, persons who travel abroad, and laboratory workers, and then next steps. Next slide. And so to make sure we all have a visual, we are here in January to present the evidence to recommendation. And the plan is to be prepared to have an ACIP vote on vaccine recommendations and finalize the MMWR in February before the next tick season. Next slide, please. Thank you.
Thank you, Dr. Paling, and we'll move on to Dr. Susan Hill.
Sorry, Dr. Lee, and thank you, Dr. Paling. Good morning, everyone. Next slide. So as Dr. Paling noted, I'm going to start today with presenting some data to follow up ACIP member questions from the September ACIP meeting. At that meeting, several members had commented on the challenges of the TBE vaccine schedule in terms of travellers having sufficient time to finish the primary series of vaccine before travel, because a minimum of 5 to 6 months is needed to complete the 3-dose primary series. The work group had discussed this issue and agrees with this concern, but I wanted to briefly present some data to show why we think it's important, if possible, to complete the 3-dose FDA-approved schedule before travel. Next slide. So this slide shows seropositivity rates at various intervals after doses 1, 2, and 3 of the primary series in adults, and is broken down by age group into rates for younger adults aged 16 to 49 years in blue, and older adults aged 50 to 79 years in green. Next slide. Beginning on the left, and after only one dose of vaccine, right before the second dose was given at 12 days, the seropositivity rates were 52% for younger subjects and 27% for older subjects. Next slide. Once dose 2 was administered, seropositivity rates measured 3 weeks later had increased to 97% in the younger age group and 88% in the older age group. Next slide. Subsequently, at 3 months and 5 months after dose 2, seropositivity rates had dropped to 71 to 79% for the younger age group and 61 to 65% for the older age group. Next slide. Then after dose 3 was given, seropositivity rates measured 3 weeks later had increased to 99 to 100% in both groups. Next slide. So this slide shows geometric mean titer, or GMT, data from the same study. And while there is no formal TBE correlative protection, a neutralizing antibody titer of 10 or higher is commonly considered to be a surrogate marker of protection, and that red dashed line shows that value of 10. Similar to the seropositivity results, GMTs are again higher in the younger adults, shown in the blue, compared to the older adults, shown in the green. For both groups, at 3 weeks after dose 2, the GMT is moderate, but at 3 months and 5 months after dose 2, the GMT has dropped and is close to the seropositivity cutoff of 10. When dose 3 is given, there is a robust response with a 9 to 15-fold increase in GMT. Next slide. So this slide shows data from a study with children aged 1 to 11 years, with data at 1 and 5 months after dose 2 and 1 month after dose 3. Seropositivity rates are represented on the graph by blue columns and the GMTs by the green line. Although the seropositivity rates decreased only slightly from 100% at 1 month after dose 2 to 95% at 5 months after dose 2, similarly to the adult results, the GMT decreased notably during the same period, from 237 initially, only 40 at 5 months after dose 2. And when the third dose was given, the GMT increased more than 13-fold. Next slide. So I just wanted to briefly present some of the key data among several studies that the work group actually reviewed, but other studies had similar patterns. So I now wanted to summarize some important points from those data. So after only 1 dose of TBE vaccine, seropositivity rates and GMTs are low, which suggests 1 dose is unlikely to provide much protection for a traveller. After the second dose, seropositivity rates and GMTs initially increase, then decrease in the following months. Of note, there is clear variability in the response by age group, with lower rates and GMTs in older adults. And importantly, while there is no correlative protection for TBE, it is concerning that GMTs are close to the seropositivity cutoff within a few months of the second dose. Finally, administering the third dose of the primary series results in an increase in seropositivity rates and a notable boost in the GMTs, often with a 10-fold or higher increase in GMT. Next slide. So as a result of considering and discussing these findings and data, the work group considered it was important to recommend a 3-dose primary series be completed prior to a traveller's departure, in line with the FDA-approved schedule, if at all possible. However, The results from studies on immunogenicity after only 1 or 2 doses will be included in the MMWR document to allow healthcare providers to counsel individual travellers if they are unable to complete the full series prior to travel. Next slide. For the remainder of my presentation, I'm going to discuss the evidence the workgroup considered in drafting the TBE vaccine recommendations and present those recommendations for ACIP's consideration. Start, I'm going to provide a very brief reminder of the key information on TBE and TBE vaccine. Next slide. So TBE virus is a flavivirus and is related to Powassan virus, which is found in the United States. There are 3 main subtypes of TBE virus, including European, Siberian, and Far Eastern subtypes. TBE virus is primarily transmitted by infected Ixodes species ticks, and infections are usually acquired in wooded or surrounding areas during recreational activities such as camping, hiking, fishing, or hunting, or by persons involved in outdoor occupations such as in the forestry service or in the military. Next slide. TBE is focally endemic and is found in parts of Europe and Asia. The incidence is variable from country to country, within countries, and from year to year. Next slide. The main risk period occurs in the warmer months from April to November when ticks are active. Next slide. In the TBE endemic region, approximately 5,000 to 10,000 cases of TBE are reported annually. In Europe, the range of TBE virus transmission is slowly increasing. Next slide. Among US persons, there have been a very low number of TBE cases, with 11 cases reported in US civilian travellers during the 20-year period from 2001 to 2020, and 9 cases among military personnel in the 15-year period from 2006 through 2020. However, the disease can have high impact. Case fatality and sequelae rates vary by TBE virus subtype. The case fatality rates ranging from 1 to 20% and sequelae rates ranging from 10 to 50% have been reported from different areas. Next slide. In August 2021, FDA approved the TBE vaccine Tick-borne, manufactured by Pfizer, for individuals aged 1 year or older. There's a 0.5 ml adult dose for persons aged 16 years and older, and a 0.25 ml dose for children and adolescents up to 15 years of age. Primary vaccination schedule includes 3 doses, and a booster dose can be given if ongoing exposure or re-exposure to TBE virus is expected. Next slide. Although the TBE vaccine is a newly licensed vaccine in the United States, the current formulation of the vaccine has been available for more than 20 years internationally, and more than 75 million doses have been administered. It's currently marketed in about 30 countries, primarily in Europe. Next slide. So as I mentioned, the TBE vaccine workgroup has prepared draft TBE vaccine recommendations for ACI's consideration for TBE used in persons travelling abroad to risk areas and also in laboratory workers. And I'm going to begin discussing the evidence to recommendations for TBE vaccine, focusing on those for persons who travel abroad. Next slide. The policy question was, should TBE vaccine be recommended for use in persons aged 1 year or older, travelling to or residing in TBE risk areas? Next slide. The first domain of the ETR we addressed was the question, is TBE of public health importance? And we considered 5 key factors in this domain. Next slide. Firstly, TBE is of public health importance for residents of some TBE endemic countries. For example, the median incidence of reported TBE cases in European countries that reported data in 2019 was 1.3 per 100,000 population, Next slide. Secondly, TBE cannot be considered an important public health problem overall for US persons travelling to risk areas, because with a median of 1 diagnosed case per year among millions of travellers to TBE endemic countries, the estimated risk of TBE is less than 1 case per million trips. Next slide. However, TBE is an important concern for certain subpopulations of travellers because their itinerary and activities put them at higher likelihood of receiving a tick bite, or because they plan to live in or travel recurrently to risk areas. Next slide. Fourthly, TBE can be a very severe disease with variable but potentially high case fatality and sequelae rates, and there is no specific antiviral treatment. Next slide. And finally, we discussed that TBE is more an individual rather than a societal concern. TBE vaccine will be paid for out of pocket by most civilian travellers, as travel vaccines are generally not covered by insurance, and TBE vaccine will not be covered under the Vaccines for Children's program. So the individual traveller will bear both the costs and the benefits of vaccination. Next slide. So the work group's conclusion on public health importance was varied. For the US travelling population overall, TBE is not a problem of public health importance, but it is a concern for certain individuals who are at a higher risk of a severe disease which can result in death or permanent sequelae. Next slide. In Domain 2, we considered the benefits and harms of TBE vaccine, with the results based on the grade assessment. First question was, how substantial are the desirable anticipated effects? Next slide. The outcomes we aimed to assess were protection from disease after the 3-dose primary series and after a booster dose at 3 years after the primary series. However, there are no efficacy data for TBE vaccine, and low TBE incidence would make such trials infeasible. In the absence of efficacy data, we reviewed immunogenicity data, but noted 2 limitations. Firstly, while a neutralising antibody titer of 10 or higher is typically used to indicate seropositivity, there is no established immunologic correlate of protection for TBE. Secondly, the vaccine is based on a European subtype TBE virus, which is one of the 3 main TBE virus subtypes. There likely is cross-protection against the other 2 TBE virus subtypes, which are those transmitted in the eastern parts of the TBE endemic region, but the supporting data are limited. Next slide. So to assess initial seropositivity after the primary series, data were from 10 studies, including 7 adult and 3 pediatric studies, and all were observational studies. At 1 month after the primary series, seropositivity rates were 96% or higher in all but 1 study. Next slide. When subjects in one of the adult and one of the pediatric studies were followed up at 3 years after the primary series, which is immediately prior to the booster dose, seropositivity rates remained high at 94% or higher. Next slide. To assess seropositivity after the booster dose, there were 2 studies, one among adults and one among children, and they were observational studies. At 1 month after the booster dose, seropositivity rates were 100%. At 5 years, they were 94% or higher. And at 10 years, seropositivity rates were 85% or higher. Next slide. Based on these data, we considered the desirable anticipated effects were large. Next slide. The next question was, how substantial are the undesirable anticipated effects? Next slide. For this question, the work group reviewed data on serious adverse events. In 4 randomized controlled and 9 observational studies among almost 7,000 adult and pediatric subjects who received at least 1 dose of vaccine in the primary series, there were no vaccine-related serious adverse events reported. In 3 active post-marketing surveillance studies among almost 2,700 adults and children, there was 1 vaccine-related serious adverse event, which was a febrile convulsion in a child with the possible contributing factors of concomitant rhinopharyngitis, gastroenteritis, and otitis media. Next slide. Based on these data, we considered the undesirable anticipated effects were minimal. Next slide. We then considered the question, do the desirable effects outweigh the undesirable effects? Next slide. The workgroup noted that there were high seropositivity rates and no serious safety concerns, and that vaccination can prevent a rare but potentially serious untreatable disease. However, we noted that healthcare providers should discuss the balance of desirable and undesirable effects with individual travellers based on their itinerary and activities. As with any vaccine, rare serious adverse events can occur, and for some travellers, even a low probability of a serious adverse event might be higher than their disease risk. So vaccination should be targeted to travellers at higher risk for disease. Next slide. Overall, the workgroup determined that if the vaccine is used in line with our proposed recommendations, the balance of desirable and undesirable effects favours the intervention. Next slide. The grade assessment results were used to determine the overall certainty of the evidence for the critical outcomes. Next slide. For protection from TBE, the overall certainty of the evidence was low. Certainty was downgraded based on results being from observational studies only, and for indirectness because there were no efficacy data, so the likelihood of protection from disease was based on seropositivity with no established correlate of protection, and because there is unconfirmed cross-protection against non-European TBE virus subtypes. Certainty was upgraded because of the magnitude of effect. Next slide. For serious adverse events, the overall certainty of the evidence was moderate. Some data were available from randomized controlled trials, but evidence was downgraded because of the risk of bias from inadequate blinding. Next slide. For domain 3 values, 3 studies inform the workgroup's response on the extent to which the target population feels the desirable effects are large relative to undesirable effects. Next slide. The first study investigated TBE vaccination practices of non-US adults who had travelled to a TBE endemic country, and this included travellers from Canada, Germany, Sweden, and the UK. Among 365 travellers who had engaged in an activity that put them at higher risk of TBE, only 15% had received vaccine before their trip. Next slide. The most frequent reason given for lack of vaccination was a perception of insufficient risk. These results suggested that even in a higher risk setting, travellers had variable attitudes towards the value of vaccination. Slide. A second publication investigated TBE vaccination rates among residents of Sweden, where TBE is focally endemic and TBE vaccine must be paid for out of pocket. TBE vaccination rates were 33% in residents of risk areas and 18% in other areas, again suggesting variable attitudes towards vaccination, even in the context of ongoing risk. Slide. And finally, we reviewed one publication of US population perceptions of vaccination, where the considerations were for Japanese encephalitis, or JE. And we considered this study because there are many similarities between JE and JE vaccine and TBE vaccine. And these include that the disease risk for travellers is very low. However, the potential impact of disease is high. Both vaccines are safe and effective, and both vaccines are high cost at over $250 per dose. Next slide. When participants were presented with information describing the low risk of JE but the potentially high consequences of disease, data on the vaccine's good immunogenicity and safety, and information on the vaccine's cost, the responses from the almost 6,500 participants indicated 43% were very or somewhat unlikely to be vaccinated, 25% were unsure, and only 32% were very or somewhat likely to be vaccinated. Next slide. When noting factors important in their decision, some valued the availability of vaccine to prevent a disease with potentially serious outcomes and no specific treatment, and others were less likely to value an expensive vaccine with the possibility of rare serious side effects. Next slide. Based on these findings, the work group determined that it is likely the US traveller population will have variable opinions on whether the desirable effects of vaccination are large relative to undesirable effects. Next slide. The work group similarly determined that there likely will be important uncertainty or variability in how much people value the vaccine. Next slide. The main fall was on acceptability of TBE vaccine. Next slide. No formal evaluation of acceptability was undertaken, but the work group discussed acceptability for the groups we considered to be the key stakeholders, including US travel medicine and other healthcare providers and persons who travel abroad. We consider that TBE vaccine is likely to be acceptable to US healthcare providers based on the attitudes and practices of European healthcare providers. TBE vaccine has been available in Europe for decades and is actively recommended by European healthcare providers for higher risk travellers to endemic areas. For the public, TBE vaccine recommendations are expected to be acceptable because vaccine availability gives an option in addition to tick-bite prevention measures for protection from a potentially severe disease. Next slide. The work group therefore thought the intervention would be acceptable to key stakeholders. Next slide. In Domain 5, the work group considered if TBE vaccination is a reasonable and an efficient allocation of resources. Next slide. Cost-effective analysis for TBE vaccination of travellers has not been conducted. Most travel vaccines are not cost-effective, and TBE vaccine for travellers is not likely to be cost-effective because the number of US travellers needed to be vaccinated to prevent one case is very high. However, the work group noted that cost-effectiveness considerations are less relevant for a travel vaccine when the decision on vaccination is for an individual traveller and not being made for the population as a whole, when the vaccine is typically paid for by the traveller themselves and is generally not paid for by insurance, and given the vaccine is not covered under the Vaccines for Children program. Cost-effectiveness analysis have been conducted in some endemic areas, and when they have been conducted, results have been variable. Programs are often not projected to be cost-effective, with incidence and vaccine costs being important variables in predicting cost-effectiveness. Slide. The work group also considered resource allocation issues. So vaccine recommendations targeted to higher risk groups are probably an efficient use of resources, as the financial implications of vaccine purchase will be borne by travellers most at risk of a severe disease, who will therefore receive the most benefit. However, even among higher risk travellers, there will be variability in whether vaccine purchase is a reasonable allocation of resources based on several factors, including the actual risk of disease, the likelihood of use of other tick prevention measures, and opportunity costs, such as buying TBE vaccine versus purchasing travel insurance or other vaccines with available financial resources. We also considered under this domain that healthcare costs for management of TB neurologic illness are potentially large. Next slide. So based on these factors, the work group therefore determined that whether TBE vaccination is a reasonable and efficient allocation of resources varies depending on the individual traveller. Next slide. Domain 6 was on equity. Next slide. TBE vaccine will cost more than $750 for a primary series and will be paid for out of pocket by most travellers or by insurers or employers in some cases. Currently, the approach to TBE prevention for US travellers is tick bite prevention measures. So vaccine availability could lead to health disparities because some travellers will have the resources to pay for the vaccine or have it paid for, and others will not. However, the absolute risk of TBE is low, and only a small number of travellers will require vaccination. So overall, vaccine availability will not cause substantial population disparities. Additionally, the work group noted that TBE vaccination recommendations cannot address this issue. Next slide. And the work group's conclusion was that health equity was probably reduced by TBE vaccine availability. Next slide. For Domain 7, we considered the feasibility of implementation of TBE vaccination. Next slide. While the work group felt that administration of TBE vaccine would be feasible as part of a pre-travel consultation, we felt the key barriers to implementation would be that the primary vaccination schedule requires a minimum of 5 months to complete, and secondly, that many travellers to TBE endemic countries, in particular Europe, are unlikely to consult a healthcare provider before travel, or will consult a non-specialist healthcare provider, and there might be a lack of provider understanding about which travellers are at highest risk for TBE and might benefit most from vaccination. To address this, CDC will be posting resources on our website once recommendations are approved. Next slide. The decision overall was that the intervention was probably feasible to implement. Next slide. So overall, when considering all the domains of the evidence to recommendations framework, the work group determined that the desirable consequences probably outweigh the undesirable consequences in most settings. Next slide. Policy option category the work group would like to propose is that TBE vaccination for persons who travel abroad should be based on shared clinical decision making. Next slide. And our draft recommendation for ACIP's consideration is TBE vaccine should be considered for persons aged 1 year or older, travelling or moving abroad to TBE endemic areas if they are at risk of TBE virus exposure through engaging in outdoor activities during the transmission season in environments where ticks are likely to be present. Next slide. The recommendations will be accompanied by additional information to ensure healthcare providers can have informed discussions with travellers about TBE vaccine and disease prevention. This will include information on factors that increase the risk of infection, including a table with detailed information on risk factors for TBE virus exposure, the need for all travellers to take precautions to avoid tick bites, advice to avoid consumption of unpasteurised dairy products, and information on general factors to consider in the decision whether to vaccinate, such as the likelihood of future travel to TBE endemic areas and the rare occurrence of TBE, but its potentially high morbidity and mortality. Next slide. So I'm now going to finish by discussing the evidence to recommendations for TBE vaccine use among laboratory workers. And again, I'll start with a brief reminder of general considerations for laboratory transmission of TBE virus. Next slide. So in laboratories, TBE virus transmission has occurred through virus aerosolization, either during laboratory procedures or handling of infected animal waste. And transmission through accidental percutaneous or mucosal exposures is possible. At least 46 laboratory-acquired TBE virus infections have been reported globally or prior to 1995. Among these, at least 4 occurred among US laboratory workers, and all of these were before 1979. Currently, fewer than 10 laboratories in the United States work with TBE virus for diagnostic or research purposes, although research activity might increase with the availability of a vaccine. Next slide. Policy question we considered was, should TBE vaccine be recommended for use in laboratory staff working with TBE virus? Next slide. Before proceeding with the ETR, I just wanted to note 2 points. Firstly, the population for vaccination was considered to be persons working with TBE virus for diagnostic or research purposes, and therefore having a scientific understanding of disease and vaccines. And secondly, the same grade assessment for outcomes of vaccination was used as was used for travellers, so I won't present the grade results again. Next slide. For the first domain of the ETR framework, TBE is a public health problem. TBE can't be considered of public health importance overall, as only 4 cases of laboratory-acquired infection have ever been reported in the United States. However, for laboratorians working with TBE virus, there is a risk of a severe disease that can result in death or permanent sequelae. Next slide. For values, we considered that scientists are likely to consider the desirable effects are large relative to the undesirable effects, as they will understand the risks of disease and risks and benefits of vaccination. We did not think there is likely to be important variability among scientists. Next slide. TBE is likely to be acceptable to key stakeholders, including occupational health directors, laboratory workers, and other researchers, as its availability will improve safety and remove a barrier to research. Next slide. For the domain of resource use, the work group felt that TBE vaccination was a reasonable allocation of resources because there are only a limited number of staff working with TBE virus, and vaccination is a small cost to pay to avoid the potentially serious impact of a worker becoming infected. Next slide. We thought that equity would probably be increased as TBE vaccine will likely be paid for by employers and will improve safety for staff at occupational risk of a severe disease. Next slide. Finally, we thought that vaccination was feasible to implement as it will likely build on existing occupational health programs for laboratory workers. Next slide. Overall, when considering all the domains of the evidence recommendations framework, the work group determined that for TBE vaccination for laboratory workers, the desirable consequences clearly outweigh the undesirable consequences in most settings. Next slide. The policy option category the work group would like to propose is that TBE vaccination is recommended for laboratory workers. Next slide. And our draft recommendation for ACIP members' consideration is TBE vaccination is recommended for laboratory workers with a potential for exposure to TBE virus. Next slide. Recommendations will be presented with additional text to provide clear information for implementation, including noting that a local institutional biosafety committee should undertake a risk assessment of the potential for exposure to TBE virus, considering the type of work to be performed and the biosafety level at which work is being conducted. And the vaccination is not required for workers handling routine clinical samples. Next slide. Next slide. In terms of next steps, as Dr. Paling noted, we anticipate asking ACIP members to vote on the TBE vaccine recommendations at the February 2022 ACIP meeting prior to the next TBE virus transmission season, and will then finalise and publish the MMWR document. Next slide. And finally, I would like to acknowledge our ACIP members, Dr. Paling and Dr. Chen, and all the ACIP TBE vaccine workgroup members and participants who have worked very hard during the last 18 months to consider the TBE data and prepare the draft recommendations. Next slide. So Dr. Lee, I'll now hand back to you. I'm happy to take questions. And if you would like, I can also put our proposed recommendations back up on the screen again for ACIP member feedback.
Sure. Thank you very much, Dr. Hill, and thanks for that excellent review, and thanks to the work group for all these efforts. I will open this presentation for questions, and I actually wanted to ask two big picture questions to the work group. One is, it sounds like we're 20 years in and 75 million doses administered. Is there any post-market efficacy or safety data available from other countries that can help inform our decision-making and augment the clinical trial data? So that's one question, and then I'll have one more.
Sure. So thank you for those questions, Dr. Lee. So there are some vaccine effectiveness data. None are directly relevant to the Pfizer vaccine. There are two vaccines that are available in Europe, and Pfizer is one of them, and there is another vaccine, and so some of the vaccine effectiveness data have considered availability being conducted in areas where there is availability of both vaccines are not directly relevant to the Pfizer vaccine. Having said that, in Austria, where the vaccine use was a majority of the Pfizer vaccine, 85 to 90% or so over the period when the vaccine effectiveness study was conducted, vaccine effectiveness was higher than 90%. So we did review those data as part of work group discussions, and we were reassured about the high vaccine effectiveness. But as I said, there were some limitations with there being both two vaccines, and also that the schedule was slightly different that was used in Austria. In terms of safety data, as you said, there has been more than 75 million doses and administered over a period of 20 years. There is no formal publication. For example, there is nothing similar to or equivalent to a sort of a VAERS publication or VAERS analysis. The manufacturer does have a safety database, and I think ACIP has seen those data, but of course that is impacted by the fact that the data that are reported to the manufacturer are more likely to be those where an event has occurred or serious adverse events have occurred. We have reached out to Europe, to colleagues in Europe several times, and asked if they have any national level reports available, asked if there is any local publications we could have access to. We unfortunately have not been able to get any additional data from them, primarily because they have been actively involved in the COVID response and have not been able to get any particular data to us. And there is no formal publications that they are also aware of. They have said in responding that there is confidence that for safe and effective vaccines, that there is no concerns given that the 20 years of use and the number of doses, but unfortunately we don't have in hand any formal publications.
Thank you. So I guess taking a step back from TBE in particular to our evidence to recommendations framework colleagues, if it's possible to consider how to incorporate these types of data in ETR frameworks. It is not typical given that we are usually focused on clinical trial data and newer vaccines, but for established vaccines, perhaps a process for thinking about how to integrate this information into our framework and decision-making. I would appreciate that. The second question I have actually relates to the recommendations for discussion, if you would be willing to put those up. And I'm going to put this question to the committee. I've expressed my opinion on the last vaccine about shared clinical decision-making versus a recommendation for use. And I'm speaking only for the travel vaccines. I would like to hear from my fellow committee members about their perspectives on the use of shared decision-making in the context of travel vaccines and when it seems appropriate. My position, at least my feeling today, is that if the benefit-risk balance makes sense and we can reasonably define high-risk situations, that it should be a recommendation. However, I want to make sure that my thinking on this is sound. Dr. Paling, since you're chair of the work group, would you like to respond?
And could I just interrupt, Dr. Lee, if I could have the next slide does have the traveller vaccine recommendations on it there. Sorry, Dr. Paling, please go ahead.
Okay, so first of all, Dr. Lee, thank you for asking this question. This was a robust discussion, and there was pros and cons in all directions. The thought process that led us to this was that it's relatively similar to the Japanese encephalitis vaccine in that it's recommended for a few persons. And so that we thought, and it's an individual benefit. And so, and that with those components, we were thinking that this is a shared decision-making. Dr. Chen is a travel medicine specialist, and I would love for him to further opine on the session. Thank you.
Yeah, absolutely. I can add my 2 cents for what they're worth. I think I myself have gone back and forth in trying to interpret and understand the shared decision-making model versus the recommendation. And, I would rather have a unified approach, but I think that through our discussions, we really did discuss the variability of risk, how we had to clearly define that is the role of that travel clinic consultation. So I can agree, and I do understand where this is coming from, Grace, that we have confidence in the safety of the vaccine. We reasonably believe that it has pretty good efficacy, although we have limited data. And so it's really a question of how we go about looking at this recommendation. Is it from the context of looking at a population-wide recommendation that we know that the population would obtain benefit versus the individual, and that many segments of the population that are not traveling certainly would not receive any benefit. So I think that that's where we've gone back and forth, and this is a wider context discussion where I think a lot of these vaccines, travel vaccines, endemic disease vaccines that exist in other countries, where we've gone back and forth on many of the work groups that I've sat on, trying to understand, but I think that it would be helpful to address this again in a unified fashion. So I've said a lot, but a lot of words, but I'm not sure if I communicated a lot, which is to say that that we did go back and forth a lot in the work group discussions.
Thank you, Dr. Chen. Dr. Sanchez?
So, well, I'll comment on your on what you asked, Grace, which I agree with you. It seems to me that although the individual may have a choice with respect to receiving the vaccine or not under certain circumstances that are posed as high risk, it seems to me that we should make a recommendation to the individual to receive it rather than have a shared decision making. It's always up to the individual to decide yes or no, but we who have seen the evidence and the studies and what is being done in those countries in which this is endemic, I think they deserve a formal recommendation from us who have evaluated the vaccine. Having said that, I do have a question. So this is in these countries that are, like, let's say for Austria and others that are providing this vaccine, do you know, is it a formal recommendation that the whole population should get it? And also, at what age are they receiving it? Is this something that is, do you know at what age they're getting this vaccine? Is it in adolescence or adulthood when they are venturing more out, or how is it utilized in these endemic countries?
Yes, thank you for that question, Dr. Sanchez. So there is substantial variability in recommendations for TBE vaccine use in, and let me focus on Europe in particular, and who the vaccine is recommended for, and the countries that actually do and don't have recommendations. Approximately 50% of countries have recommendations that are in an endemic area. So certainly some do and some don't. So it's not invariable for the countries that do have areas of endemicity for them to have a recommendation. When there are recommendations, they're again variable from country to country. So, for example, Austria does have a recommendation for all the population, but they're the only country with a national recommendation. Germany, for example, has a recommendation for vaccination for persons who live in their higher risk areas, and they define those higher risk areas, but not everywhere. The variability then ranges for a recommendation only for those people who are occupationally exposed in some countries, only for those that are going to be undertaking extensive outdoor activities in other countries. So, yes, certainly not every country has a recommendation, and when there are recommendations, it's rare that it's for the whole population. When vaccination recommendations are made, for example, in Austria, it is starting from young children, so children 1 year of age and older. Germany, again, is sort of from young children. But again, for those countries that don't recommend it for their population, but only recommend it, for example, for occupational risk, then that would clearly be adults. So again, substantial variability.
Do you know the uptake in those, in those countries?
Yeah. So Austria is round about, it's over 80%. In other countries, it's typically low, typically around about 25%, or a much lower percentage uptake. So there is variability that's based both on personal choice and also because of it's not reimbursed in most places. So it's a personal choice to get vaccinated and pay for the vaccine out of pocket for many people in those areas.
Thank you.
Thank you. Dr. Brooks?
Yes. In the beginning, you stated it's a 3-dose series with a booster. So can you comment on the booster versus when one would need to have, I guess you showed 3 and then the booster, when they would be fully protected to the best of the vaccine's abilities. And the duration of protection, that was something that came up with the last vaccine, the cholera vaccine.
Yeah, thank you for that question. So after the 3-dose primary series, there is high seropositivity for several years, and very good rates of seropositivity at the time the booster is recommended, which is 3 years after the primary series. After that booster dose is given, there is very good seropositivity rates through at least 10 years after the booster dose. So there is, following the 3-dose primary series, there's good protection for several years, and then after that booster dose, for many years, there is good protection. Seropositivity, not protection, as we don't have a correlative protection, but high seropositivity rates.
Thank you.
Dr. Cotton?
Thank you. I actually do a fair amount of travel medicine, although predominantly in immunocompromised patients, but nonetheless, I've done a lot of travel medicine over the years. I think I'm struck by the overall paucity of cases, 11 cases in 20 years in civilian travelers and 9 cases in military personnel over a 14-year period. I would not want to make this an official recommendation for travel to that region. I would definitely want to go with shared clinical decision making, because I actually think it's pretty rare that this would be warranted. I would be very happy to have it available, because there have definitely been cases where I thought that people were at risk and I would have liked to have access to it. But I don't think that it's something that should routinely be given, for say, all travel to those regions, because I think we would really over-vaccinate people for a relatively low risk. So I just wanted to express that perspective. Thank you.
Thank you, Dr. Cotton. Dr. Long?
I think we're confusing a little bit what shared decision making might entail in this regard. I think of shared decision making where there really is a potential difference in how an individual values the vaccine or values having protection. I would think that what in this situation, the only decision making would be how high is your risk? And that might be very difficult to define on a population basis and not so difficult to define on an individual basis, which would be degree and length of exposure in areas where the virus is endemic. And that if we all imagined a person who had the highest risk, what we would want, I think, is that there not be variability in the clear recommendation for such a person to be vaccinated. So I think the difficulty is that to differentiate individuals or make some rules that would define that high risk or degree of and length of exposure. But I don't think that shared decision making, I don't think of as that. I think of it more as an individual value rather than determining the individual risk. If there was the individual risk, we would want to make a recommendation that there not be variability in the use of the vaccine in that individual.
Thank you, Dr. Long. I agree with your statement about distinguishing between risk-based recommendations and shared clinical decision-making recommendations. We'll move to Dr. Kane.
Yes, so can we equate, looking at the duration of immunity, where you noted that you had high seropositivity after 10 years, but you required a booster dose, a third dose, in order to increase the geometric mean titers. So do we know that at 10 years that the geometric mean titers are sufficient for protection, or we just know that there's antibody there, but we're not sure about the level of protection? I'm asking, were geometric mean titers done as a part of these studies for the duration of immunity?
Thank you for that question. Geometric mean titers were assessed for up to 3 years after the primary series, and up to 10 years after the booster dose. But as you note, there is no correlative protection. There is no formal correlative protection for TBE. So we cannot definitively say that somebody with a particular neutralizing antibody titer is definitely protected. We don't have vaccine effectiveness data. We assume that a GMT of 10 equates with protection, but no, as you're noting, we do not have a formal correlative protection that is agreed on for this disease.
So in response to that, so we're giving just a one-time recommendations for this vaccine series for laboratory workers. They don't have to worry about, depending on how long they're working in that environment, that they need another series of vaccines.
They would not require another series of vaccine. They will of course complete the primary series and consideration of the booster dose. There may be a consideration of potential additional doses for laboratory workers. Clearly, because we don't have a correlative protection, we don't have definitive data, but certainly if we had a laboratory worker who was working with live TBE virus and had a neutralizing antibody titer less than 10, then we would certainly, encourage the local biosafety committee or those advising them to consider an additional dose of vaccine. As I mentioned, with the laboratory worker recommendations, there will be additional information saying that, of course, a local biosafety committee should be involved in considering the level of risk of the individual and the activities they're undertaking, and we consider that is a critical part of consideration of vaccine recommendations for laboratory workers.
Thank you.
Thank you. Dr. Baker.
Yes, as you know better than I do, some of our viral vaccines that are recommended as a 3-dose primary series, and given the data you showed on serology after the second dose, and you probably can't answer this question, but do you have any data after someone has had 2 full doses and then been exposed, whether or not that might prevent disease? I doubt you do, but I'm just curious whether anybody has looked into that.
So there is some vaccine effectiveness data. Again, we don't have that specifically for the Pfizer vaccine, given the availability of more than one vaccine in Europe.
And is it encouraging? I mean, is there any hint that if you had a reasonable titer, a GMT as you showed after 2 doses, that even though you hadn't had your 3rd dose, you might be protected based on serology? And I know there's no correlative protection.
Thank you for that question. It is a good question. I think there's a couple of considerations, and we don't have the data to really look closely at what some of those considerations would be. So, for example, we know that the seropositivity rates are variable by age. So older persons don't have as high seropositivity rates or neutralizing antibody titers as younger people. So that's one factor about who we're actually talking about, whether it's a child or whether it's a person aged 75 years of age, for example. The other question we'd want to be looking at is, at what time point are we looking at? Are we looking at the month after the second dose, or are we looking at 5 to 6 months later, and sort of considering that issue? So it's a little bit nuanced, and we don't have those data to answer definitively. But for people who get 2 doses and are maybe traveling during the subsequent TBE virus transmission season, they immediately, if that's a short trip, they are likely to have seropositivity rates. But given the various nuances in terms of age and in terms of how long somebody may be traveling for, and knowing that their neutralizing antibody titers might decrease over time, we were not willing to make a recommendation for just 2 doses for travellers travelling. However, we will have that information, so healthcare providers can refer to that when they're counselling travellers and sort of discuss these issues with them.
And a last question, I'm sorry, Dr. Lee, for you or anybody else. Shared decision-making when you're talking about travel vaccines. I ran a travel clinic for 10 years. Most of the travelers are sent there by their employers. I'm talking about the majority of referrals to a travel thing. And it is shared decision-making because they don't know anything about the disease. But there are people, even if they know about their potential risk, who will refuse. My question, Dr. Lee, to you or anyone else, is does that have, if the traveler has insurance coverage, does that affect reimbursement? A recommendation for a travel vaccine versus shared decision making. Thank you.
Thank you, Dr. Baker. I invite any of my colleagues to respond, or any of our colleagues who specialize in the ETR framework discussions to respond. But my 2 cents, actually, and you're bringing up a third issue that I think is completely relevant to the travel vaccines, which is this issue of equity, access, and affordability. So I recognize that this is the way our current system is, I don't know if it makes sense if that's how it should be, given that if we do think that the risk is high enough for any individual for a particular disease, it seems to me we should not be asking people to have out-of-pocket costs if they are at high risk for an illness, and recognizing that if they come back and need to be hospitalized or there's concern for subsequent spread, that we wouldn't be covering it. So I think that's a basic issue that we can't fix through recommendations, but just want to recognize that equity, access, and affordability issue is driving this, and that likely does contribute to shared clinical decision-making around the use of these vaccines. Unfortunately, we don't want cost to be a factor in their decision, but it practically is. But I'm going back to the principle, and this particular category I think is so challenging, and it means different things to different people. I am hoping that as we apply it to travel vaccines, and we have many that are on the table, that we can at least use a consistent approach to thinking about the framework for when it is appropriate to use. I'm advocating for something that is that clarifies what Dr. Long said, which is that if there is unclear benefit or unclear vaccine adverse events, a high risk of vaccine adverse events, or perhaps inconsistent or incomplete effectiveness, then I do believe that is appropriate for shared clinical decision-making. However, I do want to make sure that we are consistent with our risk-based recommendations from the past for routine vaccines as well as travel vaccines, that if somebody actually goes to a very high risk in area, that we would recommend it unless for some reason the benefits and risks are not clear for that particular vaccine, regardless of their risk of infection. But again, that's my perspective today. I can easily be swayed. I just want to make sure we have clarity on this. I'm going to actually go to Dr. Barnett and then Dr. Daly.
Thank you, Dr. Lee. I have one question for Dr. Hills and then a comment. The question is whether there are now or are planning to be any data about shortened dosing intervals for last-minute travelers. And the second comment is that this vaccine does differ a bit from other travel vaccines. Travelers to Europe do not typically go to travel clinics for preparation, and therefore might be asking a wider range of providers about advice about this vaccine. And I agree with all who have said that the recommendations that are derived will need to be very clear and specific about who would be at greatest risk and would need this vaccine. And I look to the recommendations written for Japanese encephalitis vaccine that were written with that in mind, but that vaccine is mostly given in travel clinics. So I think that we do need to wrestle with the issue of whether 2 doses is sufficient for a traveler who is leaving in 6 weeks, because the provider will be grappling with the issue of whether 2 doses is better than 0 doses or not. Thank you.
Dr. Hill, do you want to make a comment?
Yeah, I mean, in terms of the 2-dose issue, I think the work group concerns, as I said, were that indication that there is variability by age. So, in the older person, we may not be, comfortable telling them they've got very good protection for 6 months after that second dose. And also, the person who's traveling for 1 month as opposed to 8 months, clearly their seropositivity over that period is going to be very variable. So our consideration was that it's important to have that 3rd dose if at all possible, and that is the FDA approved schedule for 3 doses. However, as Dr. Barnett mentioned, that data is going to need to be available, and we'll make that very clearly available in the MMWR document so that healthcare providers can refer to that and appropriately advise travellers if they've only got time for 2 doses about what their likely protection is. And again, there is that's sort of similar as with Japanese encephalitis vaccine, and we presented the data in the MMWR document for that vaccine if travellers only had time for 1 dose, for example, before their departure. So we will definitely prioritise making that clearly available for healthcare providers.
Do you have any comment about shorter dosing intervals?
So for adults, the 2 doses can be given at 14 days apart. For children, it is 1 month apart, and I'm not aware of any studies that are looking at an earlier administration of the 3rd dose.
Thank you. Dr. Daly.
Yeah, just a quick comment that I think if possible, we should strive for some consistency in the way we approach vaccines recommended for international travelers. And I think it seems like to me that shared clinical decision-making wasn't sort of designed or intended for this purpose, but it is striking that there's different interpretation by work group, or that implies that there'll be different interpretation by providers and patients too. But I guess to me, it boils down to what would you say for the patient in front of you who self-identifies as going to a high-risk area. And so I guess I would lean towards the approach recommended by Dr. Long and by Dr. Lee. Over.
Thanks, Dr. Daly. Dr. Paling.
So first of all, I want to say thank you to everybody for all this robust discussion. And then I wanted to directly respond to Dr. Burnett's important point. And one of the conversations that we had in the work group is that some people will definitely present where they can only get 2 doses. But if you're going to be in an endemic area for a long time, you can actually get the 3rd booster dose in that nation when you're overseas. And so trying to balance all of those in the conversations is part of what the work group discussed. Over. Thank you.
Thank you, Dr. Paling. Dr. Lair.
Dr. Lee, this is I was wondering if I could present just a little bit of additional data that may help the ACIP members understand why we chose shared clinical decision making. Would that be acceptable to you before we continue with the discussion?
Sure, please go ahead. And I see Dr. Lear's and Dr. Bell's hands up. So we'll ask hopefully them to comment on this after you present. Go ahead.
Could I please have slide 103? So a lot of, as Dr. Paling and Dr. Chen said, we did discuss this issue at length. And a lot of what our concern was in making a recommendation was, and I'm hearing, very clearly feedback saying if we can define the high-risk group, then we need to make a recommendation for that group. And our problem has really been being able to say very definitively what that high-risk group is without that conversation happening between the traveller and the healthcare provider. So I've heard several comments about, if we can say the traveller, if the traveller is travelling for this period of time and undertaking high-risk activities. But we did look closely at those data, and we saw that the duration of travel was actually there was no apparent cutoff that would be make sense to include in the recommendations. So for the 11 US travellers with TBE, the median duration of travel was 18 days, or roughly 2.5 weeks. And the range of travel duration was from 7 days up to 2 months. So again, recommending, this represents the travellers who have gotten TBE, but recommending vaccination for any traveller to Europe who may be travelling for 7 days and say they're going to be hiking, for example. We were very reluctant, given the risk benefit, knowing that we've, as was mentioned earlier, we have had so few cases. So really, there's very low risk overall for US travelers. What did appear to be more important than duration of travel was the activities that travelers were involved with. Again, there's variability within that whole group. So, of the 11 travelers, data on activities was unavailable for 3, but among the remaining 8 travelers, they all reported activities that put them at higher risk of a tick bite. So 3 were hiking, 2 had substantial outdoor exposure in rural areas, 1 who'd been camping, 1 who'd been fishing, 1 who'd been trail running. So the activities were more important, but then again, that doesn't define for us a group. Like we would be reluctant, given the very small number of cases, to recommend anyone that's going to go to Europe and thinks they might hike once to be vaccinated. So this was what led to our consideration that it would be better for shared clinical decision making so that the provider can have that discussion with the traveller. If I can have slide 104. We also thought about, well, should we recommend it for everyone that's moving to a TBE endemic country to take up residence, because that, the increased duration of time in an endemic area might increase their risk. However, again, it's more related to their activities than their duration of travel. So, essentially, unlike mosquitoes, because mosquitoes will actually come and find you and sort of come and bite you, you actually have to go into a tick habitat to be exposed to ticks. So you've got to actually physically, brush past vegetation where a tick is. So, the vast majority of people who are traveling to Europe are not going to be at risk. So really defining in a recommendation specifically which travellers are going to be at most risk, is very, very difficult without that discussion happening between the healthcare provider and considering, the various factors. The European recommendations, as I mentioned earlier, they don't uniformly recommend vaccination, even for those living in areas with TBE virus transmission. So, for example, some countries recommend vaccination for those in some of the higher incidence areas, but those residents who live in a lower TBE endemicity area, vaccination is not recommended. So again, it's sort of it's difficult for us to definitively make a recommendation if they're going to a TBE endemic area when they're sort of even decision making with recommendations at a national level for the population within these countries. So given these factors, we sort of thought that it was going to be very important for the various factors like, what activities they're undertaking specifically, where they're going within a country, and we are planning to put some information together so providers have access to that information, because certainly, not everyone that goes to Switzerland, for example, is going to a TBE endemic area. So it's those factors that are challenging. And just one final slide, which is 107, if I can have 107. So we did try and sort of estimate the TBE risk for US travellers to Europe or China. And I'll start by saying there were some major limitations in trying to make this estimate. And we had to incorporate multiple assumptions because some of the data needed for the calculation were lacking. So the percentage of all travellers to Europe who visit at least one TBE endemic country was not available, and an estimate of the travellers who visit an endemic area within a TBE endemic country was not available, and then the percentage of travellers who actually undertake an activity that might put them at exposure to the risk of exposure to ticks was also, something that was not available. Having said all that, and so just sort of acknowledging the major limitations up front, you can see there that, we sort of started with thinking about all travellers to Europe, including Russia and China. And the risk there is if you include every traveller, the risk is about 1 TBE case per 37 million US citizen trips to Europe and China overall. Now that's clearly a major underestimate because many countries in Europe have no transmission or only sporadic transmission. So many travellers aren't at risk, but they had to be included in the denominator for that estimate. If you then incorporate information that 78% of trips are during the TBE virus transmission season, and that is supported by some survey data from the National Travel and Tourism Office, and then an assumption that 50% of trips involve travel to at least one TBE endemic area within Europe or China, then the risk is 1 case per 15 million trips for travellers to endemic areas during the transmission season. So again, it's sort of picking up on an earlier comment that, we want to make sure that the recommendations are sort of targeting the appropriate travellers because the risk can be very, very minimal. And without that discussion, it's going to be impossible to define very clearly which travellers might need to be vaccinated. If you then assume that 15% of travellers would be exposed to ticks, which is based on National Travel and Tourism Office survey data that say about 15% of travellers to Europe undertake activities like camping or hiking or hunting or fishing or visiting a national park or other rural areas, the risk comes down to 1 case per 2 million trips for travellers who visit an endemic area within a TB endemic country during the transmission season and undertake an at-risk activity. And then finally, if you include an assumption that there might be, and this is just unsupported by data, but 10 times as many TBE cases occurred as are diagnosed, as I said, that's likely a substantial overestimate. But there is likely some underdiagnosis because CDC is the only place in the US where diagnostic testing for TBE is done, and we only receive about 10 to 15 samples per year for testing. And incorporating that assumption, the risk is 1 per 219,000 trips for travellers who visit an endemic area within a TBE endemic country during the TBE transmission season. So again, I think these sort of data were really influential in us wanting to consider shared clinical decision making rather than, potentially misleading the travelling population by suggesting that if everyone going to southern Germany, for example, may want to be vaccinated because if your plan is to visit the villages in southern Germany and, or visit, landmarks or anything like that, you're probably not going to be, hiking and brushing against vegetation that, where you might be able to pick up a tick. So given these sort of risk estimates and acknowledging the uncertainty about them, this is why we thought that really, discussing with the traveller was important and sort of other factors that might come into that decision making in addition to their specific itinerary and what they're going to be doing is, even their individual personal perception and tolerance of risk, as you saw from the data that we considered for values, when people were asked to consider JE vaccination, which has similar risks and risks of disease, risks of severe outcomes, and risk of severe adverse events, only 32%, were interested in getting vaccinated or thought vaccination was worth it. So again, we thought that shared clinical decision making was important given all these considerations.
Thank you. Dr. Lair?
I would like to thank my colleagues and especially Dr. Long for helping me clarify my thinking. And I do think that we should make a distinction between risk and then the recommendation for the vaccine. So if someone has a high enough risk, then they should probably get the vaccine, and I'm willing to recommend that. What we seem to be talking about is shared decision-making to decide if they have a certain amount of risk. And that's actually not what I consider the concept of shared decision-making in the ACIP arena. My concept of shared decision-making in the ACIP arena is where the risk-benefit analysis of the benefits of the vaccine are so close that reasonable people would make different decisions. But if we're arguing about shared decision-making about risk, that's not what I think we should be arguing about. I think we should be talking about if they have the risk, which we all have to have the discussion, then do we recommend the vaccine? And in this situation, I would say yes. So the discussion is different. Thank you.
Thank you, Dr. Lair. Dr. Bell.
Well, thank you. And thanks to you, Dr. Lee, and to Dr. Long and Dr. Lair, because I do agree with this important to be clear in our thinking about when we would recommend shared clinical decision making, and I agree with the overall concept. In this situation, though, the more I listen to Dr. Hills and the point that Dr. Cotton made, it's not entirely clear to me that we can actually clearly characterize the risk. It sounds in some ways like this is a rare enough disease that actually we really don't have a good understanding of what the variables are, that in talking to a patient, we can sort of tell them what we know. But at the end of the day, it sounds to me like it's not entirely clear who should get this vaccine and who shouldn't. And perhaps there would be an argument for just emphasizing other tick prevention strategies and not a vaccination. So I guess while as I say, I agree with the points that you guys are making about differentiating between, making a recommendation in the context of a travel vaccine is what we should be doing when we are clear about what the risk is, even if it's, a narrow population. I'm just not sure about this. And I guess, I'm sort of obviously showing my lack of knowledge about this. But as I listen to the experts and the work group members, it sounds to me like it may be a very, very small group of people and with a high, involvement of personal preference in terms of who actually gets this vaccine.
Thank you. We are over time, so with that, I'm going to let Dr. Bell's comments stand, and we will take a, let's see, we were supposed to reconvene at 35 after the hour, so why don't we plan to reconvene at 50 minutes after the hour, so you have a 7-minute break, and I apologize, but I want to make sure we're as close to on time as possible. Thank you, everyone.